All right, hello everyone. Welcome to the CCPR seminar for today, which of course is terrifically timely. We are really lucky to have with us here today and also at UCLA in the political science department, Dan Thompson. So Dan is, Dan got his PhD in political science from Stanford in, is it 2020?
That's right, yeah.
2020, okay, 2020. And he works on elections and election data and has recently started branching out to a connection that many of us are interested in, which is to say health records, and just revealed to me that he's really interested to hear feedback from people in this room. So thank you very much for coming today, Dan. We're very excited to hear this talk.
Thank you so much for having me. I'm really excited to be here to share this work. This is, again, a kind of new direction for me, and I think for this research team. So we're thrilled to get feedback from folks who might have a little bit more exposure to some aspects of this project. We're kind of, most of us coming from the election side. So this is joint work with three colleagues here. One, Graham Strauss, who's in the room, and then another colleague in political science, Lynn Favrick, and a colleague at the medical school, Arash Naeem. And the kind of overarching project we're calling the political burden of disease, which is going to be speaking to how health affects political participation, and then ultimately how election administration choices can affect that disparity between the healthy and the sick in their participation. So I want to start just with just as a quick motivation with a kind of family feud of reasons why people don't vote. So here, this is just from a survey from 2022 of about 10,000 American citizens, asking and then in that survey, they ask whether you voted, and then among the people who didn't vote, they ask, well, why not? And they give them a pretty open-ended set of options. And the political scientists around here will be familiar with a couple that are kind of common responses, which is kind of it's about the election. The reason I didn't vote is because I don't like the candidates, or I didn't really know that much about the candidates. I wasn't very well informed, so I decided not to vote. And those are some of the most common responses. Some of the things that you probably hear about most in the news, and that is the source of a lot of policy conversation, are actually relatively less common responses. So things around election administration, like people saying that they tried to vote, but they couldn't because something came up when they got to the polls, or the line was too long, or they didn't have the appropriate identification in a state that requires some form of identification to vote. These things are not as common responses. Other explanations are kind of the circumstances, the challenges of getting to the polls, an apathy, not interested, I forgot, or personal life intervening. But one of the most common things, but that is basically overlooked by political scientists, despite its the rate at which people say this is a reason they didn't vote, is that people are sick or disabled and unable to make it to the polls. And so this is going to be the focus of our work. And while it's been kind of overlooked mostly by political scientists, it hasn't been overlooked by people who are designing electoral institutions. So even back before the American founding, there were already seeds of trying to address this problem in the colonies. Here is a law from 1652 in Plymouth Colony, where when voting for representatives, people who had disabilities or couldn't vote because of issues associated with their age, were granted the opportunity to vote by proxy. And this kind of approach to election administration that afforded people multiple ways to vote kind of died off at the beginning of the Republic. But in 1917, we had our first absentee voting law in Indiana that targeted explicitly people who could not vote for a reason of illness. And we have and then the system that we kind of are most familiar with today, one where people can apply to vote by mail because of an illness or other barrier to participating on election day. California instituted this in 1967. So we have this kind of progression of making it easier and easier for people to vote, people with health challenges to vote. But it's something that policymakers have paid attention to going back to before the American founding. And today, we address this in a bunch of ways. Here is just gives you a little bit of context for the state of election administration in the US. In 8 states, every registered voter is sent a mail ballot. And California being the example that we probably most have in our head. But even beyond, even in places that don't automatically send a ballot, most states allow you, even if you aren't sick or you don't have a way of demonstrating that you have a health challenge to vote, will allow you to ask for a ballot by mail and to complete it and send it back. And even in those states that don't, most of them have some kind of opportunity to vote before election day. That's a lot of us are familiar with that because we're seeing that happen in many of these states right now. And so this kind of it demonstrates, I think, the fact that our election administration is trying to many of our policymakers have been trying to prioritize and address this issue, but we don't have a very good sense of how good these efforts are at reducing this disparity. This kind of context has motivated, and of course the context of the 2020 election, where health and people's ability to participate was kind of on the forefront, has motivated two projects that are kind of a big effort that we're trying to do collaboratively between political scientists and folks at UCLA Health. And the first project, which I'm going to be focused on today, studies how much poor health, being sick or in some cases being disabled, though I won't focus on today, affects voter participation. And in this project, we are focused on California, and the goal is just to estimate this effect of health on participation, and then ultimately to use this data within California to do some exploratory analyses of the disparity of this healthy sick disparity in participation, and then. The next kind of project that we're hoping to do, and this is kind of an ongoing work to find good collaborators across the country, is to expand this data beyond California, where we have quite different election administration regimes, and use changes over time in those election administration regimes across states to study how convenience voting expansions can affect this turnout gap. And so this is something that our medical school collaborator has partners at other health systems across the country that we're trying to navigate right now. So that's this gives you a little bit of context for the kinds of things that we're looking for feedback on and advice on. As you're hearing my talk today, I'm very curious to hear which of these directions, what things we should be doing in each of these, even in this project that I won't be spending much time discussing today. Yeah.
So just to go back for a minute to the previous slide where you were talking about these changes in access to voting as addressing the disparity.
Yes.
Is there, I know nothing about this. Is there evidence that that's why these new procedures were put in place, or were they, I mean, at the same time, a lot more people were working for pay and structured jobs, both men and women. So that could also be a reason.
Of course. Yeah, no, of course. There are many reasons. My main point is just that oftentimes the first people who are identified in these are people who are sick or disabled, or people who have work that requires them to be away from the poll. And so it's but when political scientists have looked at this issue, it's basically been ignored that health is a reason people might not vote. So it's more just setting the stage of that this is actually for policymakers, at least in the text of legislation, they're often explicitly calling out, making explicit provisions for people who have health issues that might keep them from the polls.
Okay,
Yeah.
and just one other quick follow-up. So in the reasons people give for not
Yeah.
voting,
Yeah.
are those like mutually exclusive? So I could see that transportation could be a problem if I'm sick.
Yes.
I would need a ride.
Yeah. Yes. Yeah. It's yeah. In this case, I don't take this way too seriously, because in fact, you were only given one option here. Like, you had to choose the main reason. And of course, these things could all be the case, and even more so, like no individual. I don't have any like causal estimate of the effect of any of these particular characteristics. That's in fact why I think we need to go assess this credibly. Yeah.
So feel free to defer this.
Yeah.
Given that you're showing California is one of the most permissive voting regimes in the country,
Mhm.
How should we think about sort of the numbers you're showing? Should we think of these as like a lower bound to how much we think of health impact?
Yeah, I think that's exactly right. I'll talk a little bit about that kind of when I do some of this exploratory work at the end. But yes is my short answer, and as insofar as we think that this is actually the mechanism that's producing lower vote. I'll talk about this a little bit in a minute, but the quick preview is that I'm not entirely sure that election administration is the main reason that there would be these differences. That's why I think it's important to go study it. Okay. So the work that I'm going to present today, just to give a little bit more of a preview, is work where what we've done is link a voter file, a list of all registered citizens to UCLA Health's electronic health records. And what we're doing in this kind of pilot version of this analysis is to compare patients who are diagnosed with cancer shortly before and shortly to those before an election to those diagnosed with cancer shortly after an election. And I'll talk a little bit more about the details. But what we find is that cancer diagnoses before the election, people who are diagnosed before the election rather than after, have turn out at about 3 points less than people who are diagnosed after the election. And this effect is about twice as large for people who tend to vote in person as compared to people who who have voted absentee in the past. And yet, the effect of this diagnosis, for the reason I think perhaps for the reason you're describing, the effect of the diagnosis is similar even in 2020 when every person was for the first year in which every person was sent a mail ballot. Everybody who was registered, so everybody in our data was sent a mail ballot. Okay. So why is it that we might expect health to affect participation? Here's just a simple kind of framework that we're using in our discussions about it. I'd be very curious to get feedback on whether this framework makes sense to y'all. But the kind of first order kind of direct effects of health on voting would be that many conditions and their treatment reduce mobility for one reason or another. And so this might raise the cost of voting in person or obtaining an absentee ballot if I have to get to the polls. So if there are things that if there are physical actions I have to take, getting out of bed to go do those things might be harder. Or getting out of my house to go do those things might be harder. Getting there through whatever mode of transportation might be harder. Those are the types of direct effects that we might think might make it harder to vote, especially if you had to vote in person or go in person to obtain an absentee ballot. But there are also important kind of changes in your in the opportunity cost of voting, and so health issues may require time-consuming treatment or raise the value of rest, and so if these alternatives become more important, more valuable to you, you may be less likely to vote. Of course, there's also kind of, as I talked about right at the beginning, one of the main reasons people don't vote is because they're not interested in the election. And it may be that these changes in costs are not so significant, but that really what motivates people from their health is that either they are sicker and they're less interested and less engaged in politics, or they're sicker and they see the personal significance of health policy as something that they need to go and make their voice heard on this issue. And kind of related to this, but I think important to say is that it's also perfectly plausible to me as a political scientist that because interest in the race is so clearly an important factor in determining whether people participate or not, all of these other changes you might expect to be relatively small, and so health might not have much of an effect on participation at all. Yeah.
My first instinct would have just been to think that a cancer diagnosis would trigger a psychosocial pathway. Just
Okay.
stop.
So can you say more?
Just, I'm too depressed to think about this election. I mean, I feel that way the next night.
Yeah.
I mean, just, that would be kind of prima facie my kind of first instinct. And
Sure.
especially because with a cancer diagnosis, you're still the same person.
Yes.
With the same health. Now, the treatment obviously might
Yes.
start right away, but often with a lag.
Yeah.
So
Yeah.
to me, it's the news that would be dominating the other news.
Yeah, absolutely. I mean, one thing I'll come to you. One thing that we've started to work on. I'll talk a little bit more about the data and where the challenges are in terms of being able to identify this. But one of the things that one of the next steps that we're hoping to do is to zoom in really close to the diagnosis, so it's less plausible that you've started a treatment regimen. Right now, we're including people who were diagnosed as long as a year before. And so in those cases, we might think typically we would think that those people are already pursuing some kind of treatment if they're going to. But this point about that's kind of what I was getting at with this kind of the less interest is I think a perfectly reasonable expectation. I'll come to you.
I sort of quick question. So the control group are people that were diagnosed after the election, and the treatment are diagnosed before this election. I guess my question is your assumption that the treatment group is in much worse health than this control group?
Yeah, no, not necessarily. I mean, presumably they must they've gone in to seek some diagnosis and then ultimately treatment. Of course, for this particular disease, there are other conditions that we would like to study like this, but for this particular disease, presumably it's not like so sharp, the actual experience of the disease.
So that's what we're capturing. We're not capturing the difference in diagnosis. We're capturing differences in health.
I think no, what we're capturing is the difference in diagnosis. That's what we're actually gonna be able to observe. Now I think it's gonna be correlated with differences in health, and it'll certainly be correlated with differences in how exposed to treatment you are. Because the people who are diagnosed after certainly won't have been treated, and so won't have been receiving cancer treatment, I should say.
I have one follow-up question. Do you think that people who seek treatment earlier may be just more conscientious? Like if I go to the doctor more often, maybe I'm more likely to fill out my ballot earlier or participate in my election.
Yeah, yes, that would totally make sense to me, that people who pursue treatment would be but relative to the election, I don't think it has anything to do with the timing of the election. So we should have a similar number of those conscientious early people after the election and before.
So my comment was related to Randall's, and I was thinking of, when you get the diagnosis, your whole world kind of,
Yeah.
Your ability for planning things.
Yeah.
So I was thinking in terms of the implications for planning. And
Yeah.
while it may not really impact your analysis, it probably does not impact your analysis for California. I think it very well could impact your analysis for other states where it requires people to plan,
Yeah.
to register, to be registered 15 days, 30 days in advance. So it's not just about in-person voting, but all the other things that some states require someone to do
Sure.
to prepare to vote.
Sure.
And I would make that, I would point to that mechanism, like ability to plan, as impacting a lot of people in those other states. Health-wise with your study, but also kind of generally the ability to plan is something that is a potentially a mechanism.
Sure. Okay, great. That's super helpful. Yeah, and I think as we go along, I'll talk a little bit more about other potential things that we think we can identify well in the health records. That I'd love to talk about how I may be able to cut between the particulars of cancer and other conditions that might not have some of the same qualities. Okay. So a little bit of context on what the literature on this looks like before coming in. This is stuff that I've, oh yeah, sorry.
Sorry, I had just one last
Yeah.
question on, so on the last slide, so
Yeah.
are you gonna be able to look at heterogeneity in terms of what stage of cancer they are at in diagnosis? Because that could help disentangle, like, are they like already probably feeling very sick for the diagnosis or not?
Yeah, that's a great suggestion. We haven't looked at it, but we have it. So like we have it. I don't think we have it in the current data, but we do. I know that the cancer registry that we're using for this has that very clearly labeled. Like, and I'll talk about it, but that is something that we should be able to use. So that's a great idea. Yeah. Okay. Okay, so a little bit of context for what the kind of existing set of patterns is before we come to look at the data that we're putting together. So in this survey that I told you about before of about 10,000 folks that's taken every even year election since 2008. They also ask a question like, are you sick or disabled around the time of the election? And people who report being sick or disabled turn out at substantially lower rate, about 10% to 10 percentage points less. And we can see this is true over the course of the data that they have. This isn't something that was particular to 2020 or that declined in 2020. In fact, like it's a fairly large gap that's relatively stable over time. Okay. But the reason that we feel like we need to bring some intervention to this is a few kind of challenges with this. This is the kind of pattern of existing research in this area with only a couple exceptions. The reason that we think we need to bring some new analysis to this is first just that the survey data dramatically overstates participation. So just as an example, the kind of flagship survey of voter behavior in the U.S. One study in 2012 was able to validate how many of these people actually voted that said they voted, and there's over-reporting of voting by about 13 percentage points in the national election study. But a trickier problem that hasn't really been validated in this data, I suspect that in other health data, this is a common thing that people have looked at. But in this data, I haven't seen anybody discuss it, at least in political science, is the challenges around like reporting biases of health conditions. So on the one hand, people with chronic health conditions might be harder to reach or easier to reach. It's not really clear. People who are less concerned about a condition. This kind of gets to one of the points that somebody raised already, but that people who are less concerned about the condition may be less likely to report it. And so we're kind of getting a selected group of people, not the effect of the condition, but maybe something about the psychological nature of the person. And then, of course, something that we're going to be trying to address with our approach here is that that healthy and sick people and turn out at different rates for a bunch of reasons completely unrelated to health. So just looking at this survey data, people who say that they are sick or disabled are more likely to be older, have fewer years of education, more often women, and typically support Democrats by like a very large margin. Support Democrats, and so all of these other factors. I mean, of course, these are observable, and we could adjust for these within a regression or something. But there have to be a bunch of also unobservables that we can't address with in those regressions just by conditioning on these characteristics. And so what we've done is try to address each of these things in turn with our approach in this kind of pilot. So the first thing we've done is try to identify the onset of illness using electronic health records. For those of you who are unfamiliar with these, when you go to your healthcare provider, almost always you're like filling out electronic forms now. These and your doctor is sitting over there on a tablet or whatever, filling out some forms. All of that feeds into these electronic health records. Which have these standardized coding systems. We're now in this ICD-10 world, which has a lot of very detailed information about the conditions. And these are used often for billing, but also for treatment. And so there is quite a lot of rich information in these records. But in our case, and part of the reason that we've focused on the main reason we focused on cancer for the purposes of this kind of pilot is that in California, providers are required by the state to report cases of cancer, Parkinson's, and neurodegenerative disease to the state government. And the way that UCLA Health does this is that they have oncologists go through the electronic health records and identify the kind of primary cancer, when was the initial diagnosis, what's the course of the disease, a bunch of characteristics of the disease identified from looking at the electronic health records. And so it's like the best, RA doing the cleaning for you of this data. And so we're relying on that for this first pass to try to make sure we have kind of the best version of these electronic health records, and then validating with electronic health records that we'll be able to have at scale. Did I see a question?
Yeah, so is it people connected to UCLA Health, or is it the state of California?
Yeah, so in this case, we're just doing UCLA Health as this kind of pilot. Yes. Yeah, I'll show you what that means for our analysis. Yeah, so right now we're just focused on UCLA Health. We have access to all UC system health records is the kind of path that we're doing.
It's the UCLA Health, right? It's like Berkeley,
yeah, so Berkeley doesn't have a health system, but UCSF, UCSD, I forgot. There's another big one. But yeah, yes, okay. It's a bunch of the major health systems in the state of California are run by UC. Yeah. Oh yeah.
Validate.
So what we're working on right now is we have what I'll show you today is just from the manual, like the manually cleaned health records. What we have is something that is scalable to anybody who's using any health system that's using Epic, where it's just using the health records, the electronic health records directly, these diagnosis codes, to back out first the onset of disease, and replicating our results that use this kind of what we think of as like a gold standard of diagnosis measurement to the just working directly from the health records, if you see what I'm saying.
I do see what
Yeah.
you're saying, but I mean, maybe it's just a skeptic in
Mhm,
me, but the oncologists have a lot of work to do, right?
Mm.
A lot of it is patient care.
Yeah.
It seems like they have less time and effort to be able to devote to cleaning data.
Mm.
So is there some check on the quality of the oncologists?
Not to my knowledge. No. I mean, I haven't done this. When I talk to like this, we're really relying on the judgment of our co-author in the health at UCLA Health to say that this is a trustworthy measure. So, but I don't have a way to independently. In fact, like we can't even look at this data. We're given like anonymized data. So like yeah, I don't have any way. I mean, the fact that if there were just systematic noise, if there was just random noise in the data, I would expect that just to attenuate the effects. And we're seeing fairly large effects, but it doesn't give me any confidence about the point estimate isn't attenuated. So do you have any ideas, any recommendations for how to evaluate it?
I mean, some of the studies of diagnostic tests for breast cancer, for example, use AI to compare them to human reports.
So say that one more time.
Some of the research on breast cancer
Yeah.
uses AI to find and evaluate diagnostic tests, and then they compare those AI diagnoses to human diagnoses.
I see what you're saying. Yes. So in this case, this is the reliability. There could be a reliability concern about the actual diagnosis process. What we're really looking at is the full course of a person's treatment plan and all of that. So I really have almost no visibility into whether their diagnosis is accurate per se. Like that's pretty far distance from what we'll be able to see. But what I can say is that like the issues that we were most, or at least the issues that I was most worried about in discussion with this team, and the reason we wanted to use this registry versus the electronic health records off the shelf is that in some cases you could say, oh, somebody went to get got a skin biopsy just to check if there was something, if it was malignant, and then there's nothing wrong, and but that's coded because somebody's working quickly, that's skin cancer. And so that this is going to address those kinds of issues in like the quality of the diagnosis. We have very little.
Well, I mean, you're relying not just on the quality of the diagnosis, so you're also relying on the timing of things.
Yes.
So especially if you try to think about, well, how sick were they when they were first identified?
Yes. So this really gets to this point about how much what are we identifying the effect of illness, or are we identifying the effect of diagnosis, which we are really identifying the effect of being told that you have cancer, and that's going to be correlated, presumably that will be correlated with treatment and probably correlated with illness, though not in the kind of sharp way that we might, but I think hopefully, perhaps that will be better, though the cancer, the reason we focus on cancer is because of the data quality stuff with the reporting, with some of these other cases that aren't in registries, we might have a clearer kind of, the treatment might be more clearly connected to the stage of the disease. So like in the case of the next thing that we've just gotten the data on is congestive heart failure. So like somebody shows up in the hospital, it's a much more acute condition. So Okay. Oh, yeah.
That's, but this kind of data in other work, people have kind of created indices that kind of use all the claims data to categorize people as more or less healthy.
Yeah.
And I think it would be really interesting, even if you can't do anything causal, to even just see kind of with this better health data and the voter record linked to it, kind of what does that pattern look like? And how does this population that you're studying that has cancer kind of compares to that, and what is, kind of to put it in perspective, because we're missing a bunch of other people and dimensions of health.
Absolutely. So I'll just jump to that in the appendix because we've done that was the first thing we started. So what the main index that, again, this is completely outside my area, but my colleague at UCLA Health assures me that this is the way that this is most often measured, is this Charlson morbidity index. At least this is the way they like to measure it. And so we've just split this into tercile or into 3 buckets based on kind of some standard evaluation of what would be what's really poor health, what's like bad but not tremendously bad, and everybody else. And so here in the first column we have we're just showing in the cross section everybody who links between the voter file and the health records. This is just a dummy for being in the mid-level health group and the worst health the worst health group. So these are people who have large number of conditions. And as it turns out, in the cross section, the people who are the least healthy vote actually more than the people who are the healthiest. Not terribly surprising because for one reason, these are people who are appearing in the health records to begin with. So these are people who are at least motivated enough to show up to get treatment. And then also these tend to be quite a bit older. And so I'll skip over the second column because it's not super informative. But the third column, what we've done is then just include we're again, because of the sensitivity of the data, we're not allowed to see exact birth date or anything like that. But we have these age buckets of about I think it's like 10-year buckets or something like that. And once we just include fixed effects for age. The effects go the opposite way, and exactly the way that you would kind of anticipate, where people who have these kind of severe conditions, multiple severe conditions, are about 7.5 points less likely to participate or to vote than people who are deemed like healthy by this measure. And basically from there, once we've adjusted for age, almost none of the other adjustments make any difference in the correlation between health and voting. So again, it remains something like a 7-point drop in participation for people who are especially unhealthy. Yeah.
Is this cross-sectional, or are you looking at the same patient and their declining health and repeated voting?
Yeah, so in this case, we have that. This is we have a panel right now. This is just descriptively like using the cross-sectional I mean, I guess in principle it's using all of that variation, but there's no like individual fixed effects here. When we've done the work we've done the thing of including individual fixed effects. In fact, like when you go from I didn't include that in the slides, but when you go from like good, like the low morbidity index to high morbidity index, we get some effect sizes that are comparable to what we're seeing with the cancer diagnosis. But the reason we've chosen to approach the analysis the way that we have is because we spent, I don't know, 6 months working through that, trying to validate that. And what you see is just that the people who are transitioning into poor health are also are very different from the people who are not. And so finding a good even after matching the people who are transitioning into poor health, who go from a low morbidity index to a high morbidity index, you compare them to other people who consistently have a low morbidity index and score and are the same age, race, live in the same zip code, have the same exact participation history, and then you look at the election before on whether they turn out, and they turn out at different rates. So like the design just wasn't the statistical adjustments weren't giving us enough to give us confidence that what we were estimating was the effect of changes in health. So we pivoted to this approach that I'll be showing you today. Okay, I'm gonna go way back. All right. So for voter participation, this speaks a little bit to this question about what our data looks like. For the for the data on voter participation, we're going to be using a voter file. We've gotten this from a private vendor, but what's cool about one thing I want to share to everybody in this room, if you're not already familiar, you as a UCLA affiliate have access to this data. We've spent, Graham especially, has spent an immense amount of time cleaning this data and making that cleaned version available to every one of you in this room. It's available at the library, and all you have to do is if you go to ReadyViz, this website, ReadyViz, I think it's readyviz.com, and you sign in with the UCLA single sign-on, you can fill out a like one-page form and immediately get access to a national voter snapshots of a national voter file that go back from 2014 to 2020. And what's cool about this, the reason we cleaned it the way we did for this project is that oftentimes what people have when they have a voter file is just like a current snapshot of the voter file, and then they have vote history for everybody who is currently registered. What we were able to get from L2, which I think has been really valuable, is every snapshot that they've produced going back to 2014. And what this means is that we can see essentially, not exactly, but essentially what the registered electorate was as of election day for every primary and general from 2014 to 2020, hoping to update this after the 2024 election through 2022 and 2024. And then what we've done is use the IDs that they supply, where they have done a bunch of work to do linking on the back end over time. We're using their IDs to be able to easily build a panel, and it's all in the ReadyViz system. It's all set up so that you can run SQL queries on it. It's super fast, so I recommend you checking it out. We've now taken that data. We've taken that data out of ReadyViz and sent it down to UCLA Health, and and what we have there again is just these even year primary and general election measure of turnout and how you voted, whether you voted absentee or in person or early. Okay. And what do we do with these two records? We first we limit both files to people who could plausibly be going to UCLA Health or likely would be going to UCLA Health. The way we do that is that this LA County has has divided up the county. Public health officials divided the county in terms of service planning areas, as they call them, and we've just focused on service planning area 5, which is kind of the region that is most closely associated with UCLA health services. And so we're going to be focused mostly on people who live on the west side, in this region 5 that you see here. Okay. And then we match exactly on birth date and gender, just to limit the amount of string matching, string distance measures we have to produce. And then we compute a weighted average of a string distance between all candidate matches, and then select the best one from that set. And the way we do this is we do within each unique word within each name, address, and phone number, or like each token, I guess, because we've got some numbers in here, but you get the point, is that we then compute string distances between each of those tokens, and then compute a score 0 to 100 on the quality of that, like based on the edit distance between those two strings or sets of strings, and then we do we take a weighted average of those scores across addresses, names, and phone numbers, with weights heavily toward the names. And then finally, we just select the best match, but we throw out some that have that in previous work. This is being done by the team that does record linking for UCLA Health. So we've talked a lot about this with them, but they have their own. They have a procedure that they trust in terms of what counts as a minimum a distance that would mean that these two people are unlikely to be the same person, for their own their needs as a service provider. Okay, so what do? We've talked about this already a good bit, but just to lay it out formally how we're thinking about it. What we do is compare patients who are diagnosed shortly before an election, shortly after, and because of the kind of data restrictions, what we've been able to convince them to give us is just whether the person was diagnosed before or after the election within a year. And I think we're going to be able to get within 6 months and within 1 month as additional cuts. But for now, what we have is just within a year before and after. And so that doesn't allow us to do like a traditional RD. And I'm not even really sure whether that would be appropriate given some of the things we talked about here in the case of cancer, where some aspects of this bundled treatment aren't really being assigned in that kind of discrete way. But nevertheless, what we're going to be doing is we're thinking of it as akin to kind of a local randomization regression discontinuity approach, where we're just going to be taking mean on one side, mean on the other side, taking the difference in means and trying to establish that over this region, the two groups are relatively similar on observables.
And so UCLA Health has the exact precise date, and right now you basically told them the election date, and they're just telling you.
Correct. That's right. Yeah, exactly. So they know exactly when the appointment happened. But for public, privacy reasons, they only share the summaries. Yeah.
Might be getting to this soon.
Yeah.
You're comparing people in like the same stages of cancer before and after election, or is all the stages of cancer being grouped together?
Yeah, it's all stages of cancer being grouped together, but it's people it's just the diagnosis happens before the diagnosis. That's it. That's the only thing we're going to do. Yeah.
I'm thinking about these psychosocial pathways.
Yeah.
And I would wonder whether a cancer diagnosis affects whether the patient's spouse votes.
And
I wonder if you have an identifier for the spouse, either the voter or probably the medical record data.
Yes. So in the vote, I don't think we would have it in the medical record data, but we would have it in the voter data. I wouldn't be able to know that it's your spouse, but I could see if they're at this share an address. That would get. I could see your housemates vote at different rates. Yeah. That's a great idea. I know there was somebody has done something that's a great idea. Okay, so just to establish, like when we first set out to do this, because of the issues that I described with the diff and diff kind of version of this, we weren't confident. We felt like we really needed to check to make sure this was actually going to work. And it seems like it's working pretty well. So here's just the distribution of people who I'm defining treatment as defined as diagnosed before, control is diagnosed after, and the ach distributions match up pretty well. I'm not showing any of this here, but we've run like chi-square tests on this to check whether these distributions are similar, and we can't reject that the two distributions are drawn from the same. These two samples are drawn from the same distribution. Same thing is true for gender. It's a little bit easier to see here that we have a few more men in our treated group than in our control group. But again, can't reject the null of being drawn from the same distribution. Same deal with race. Our treated group is a little bit whiter, a little bit less likely to be Asian, Black, or Hispanic. So we take this as kind of evidence that that at least on these observables, the design is doing a pretty good job. And we're just going to again pick the difference in means, and then we'll also adjust for some of these observables in some of our regressions and stuff. But most of the stuff I'm going to show you is just going to be showing these difference in means. Yeah.
Say how many people are you?
Oh yeah. So we have about 9,000 diagnoses over this period. Yeah. Oh, yeah.
Just really quickly about, and I don't know that this would be, important, maybe the magnitude wouldn't be, or the frequency wouldn't be too common, but does the billing code process control for people that might have gotten a diagnosis outside of the UCLA health system and then come to UCLA or is this like initial diagnosis? You know, for sure.
Yeah. It's supposed to be. It's initial diagnosis in UCLA. The one within UCLA system, that's definitely what the health the health records are giving us. The one thing that I'm not sure about, it's an important thing for us to figure out, for me to ask about, is whether we did talk about. I know that we are not including people who for whom UCLA Health was kind of like a secondary, like getting you're at Cedars and you want to get a second opinion. Those folks aren't going to be included in here. But what I don't know is whether if you went to Cedars and you got diagnosed and then you came to UCLA Health because you were unsatisfied, whether we would pick you up as being diagnosed. I'm not sure. So it's something that we should look at. Outside diagnosis. Okay. Okay, so what do we find? So the first thing to share is just that, again, on one observable, I think the best observable thing that we could look at for establishing the validity of the design, we see that turnout in the two-year election that happened 2 years prior is basically identical in the groups that were treated, that received a diagnosis before and after the election. But then in the election that is splitting these people into people diagnosed before and after that election, the people who were diagnosed before turn out about 3 percentage points less, than the people who were diagnosed after the election. And then now you go 2 years later when both of them, which is following them both having been diagnosed, and they turn out at relatively pretty similar rates, again, with slightly lower turnout for the treated group, but not statistically indistinguishable from zero. Okay.
Why is it interesting?
What is that?
Why is it?
So like if you the main thing it's mostly that the highest turnout elections in the last century which was 2020, and the highest turnout presidential since like the 70s was 2020, and the highest turnout midterms in the last century were 2018 and 2022. So the later periods tend to be higher turnout elections. So good reason to have a control group. Is the answer to that. Okay, so what do we? So this is just some formal estimate. The actual estimates. We have again, as somebody asked, we have about 9,000 folks in here. And this is just reporting what I just showed you, the almost 3 percentage point effect on participation, a standard error of just under 1 percentage point. When we adjust for the election fixed effects, we don't see much of a difference in the point estimate. Same when we adjust for age differences across these groups. You might think that this was the big concern. One big concern I had was that maybe the people who are diagnosed earlier tend to be a little bit older. When we adjust for that, we don't see much of a change in our effect estimates. And then similarly, when we adjust for whether you voted in the last election or not, we don't see much of a change in the turnout effect. Yeah.
Just for clarification, the effect cancer diagnosis is still cancer diagnosis before the election.
Correct. Yeah, and this is so like if the election we're thinking about is 2016, we're comparing people who were diagnosed before the 2016 general and after the 2016 general, and so this is just in that election. I'm not going to look at the future election where both are now diagnosed. Yeah.
I don't know if you mentioned this before, but how many of these people died?
Yeah, so that's the next thing. That's the next thing I'm going to talk about. Let me come back to that because that's an important consideration. Yeah.
Just a quick thing. I'm so sorry if I missed this, but is it they're diagnosed since the last election, since the previous election, or any time in the past?
No, it's just this is just now comparing people who are diagnosed in the year before the election to people who are diagnosed in the year after the election. Yeah. So there's no yes, it was since the last election or since the last like type election, because in some cases we are double counting in some here. That's why we're going to be clustering by patient ID, because in some cases, like we're going to have a primary in May, and then we'll have a general in November. So you were diagnosed before the general, but after the primary. And so we're going to be using you in the control group in one case and the treated group in the other case. Yeah.
For those of us who don't work in election and turnout, can you compare these to the effects of other things that?
Absolutely. And I have one. I had one more question I want to address. I'll come to, and then I'll come.
You're only looking at the 2016 in general, or you're looking at?
Oh, yeah. So this is going to be every general and midterm since every general and or every presidential and midterm, primary and general since 2014.
I have one concern about using midterms. So earlier I said that so in the RD we want to make sure that people aren't manipulating their treatment around a date, and it doesn't make sense that I would maybe go see the doctor before an election.
Yeah.
But the midterms are held in November during open enrollment. Maybe if I know I'm changing my my insurance status, I go and get that checkup sooner. So maybe I would do a check just using generals and excluding the things.
Yeah, I see. So maybe using the primaries that are earlier in the year. Yeah. So I will show that. Yes, I will show you something like that. Okay. Okay, so to this question about the effect size, just to give you a sense of the magnitude, I'm not really sure exactly what to say. I'm just going to compare it to a bunch of things. I've hesitated on whether this is large or modest, or I don't know. But compared to what I would have expected, but compared to other things, it's a lot of other things. It's larger than many of these. So many of the things that I've studied in the past. So, for example, there's in a project I did on universal vote by mail, the rollout of universal vote by mail, that increased turnout in the general public by a little over 2 points. There's a paper on early voting, so adding a day of early voting, how much does that increase turnout? It increases turnout by about 0.2 of a percentage point. So even a really large expansion of early voting doesn't change turnout all that much. There's a paper I really like that did in 2004 ran a massive ad campaign targeted at young people. When young people were instead of watching TikTok, were watching cable news or not cable TV, like MTV and this sort of thing. So it was all on all of these cable channels, blanketed these cable channels in a bunch of parts of the country, and that increased youth turnout by 2.5 percentage points. And another colleague, political science colleague, has a paper studying the effect of buying a home on voter participation. That people who buy, because one of the biggest differences in participation is homeowners versus renters, and found that is like a 2.5 percentage point increase in turnout. And so it's large relative to these things. I don't know whether it's large relative to what we'd expect or but that's it gives you a little bit of a sense. The one concern, I don't remember who asked us, I think you were asking this about, is about one other thing that we've been kind of had in our head about this is that if you're diagnosed before, you're more likely to die before the election than people who are diagnosed after. I mean, by definition, you have to be alive to be diagnosed after the election. And so it can only go cut one way. And so we've done a few things to do this. One is that right now what we're doing is linking people who are still in the voter file on election day. And so in some sense, there is some kind of potential post-treatment bias. We've got some ideas for how to get around this, but right now, everybody has to be at least in the voter file on election day to be included in our sample. And one thing to know is that California is pretty effective at removing people who die in the state of California from the voter file because they have social security numbers and they have access to the state public health records that or death records. So the state seems to be pretty good. When I've looked at, I've done a bunch of work validating the voter file from this exact issue to look at voter fraud questions, and the state seems to be pretty good at this. But of course, it could be that still be that this is creating some kind of post-treatment bias. So one thing that we've done, I don't think it's perfect, but one thing we've done to try to get at this is to look at whether people who are diagnosed before are more likely to be missing, meaning removed from the file in the following election. And so we can look and see that they're pretty similar in the election before. Yeah.
I actually asked a clarifying question there. So if you didn't find a match in L2, are you excluding them just like?
Correct.
So because technically, I mean,
yes,
then you can't distinguish whether they die or not, but
yes,
like they are not registered to vote.
Correct.
So they didn't vote. Like I don't know if it's like a person who should be excluded or who is actually counting as part of your control group, not control group, but like as a negative outcome. Yes.
Yeah. So right now we're only looking at the people who have matched. It's something I think in the spirit of your question, I'm not sure if this is exactly what you're asking, but one thing that I think we've talked about wanting to do, if we can convince them to give us this data, would be like all of the patients, whether they match or not, but that we have some reason to think they ought to match. Like the one challenge is that, of course, there are patients who just have very poor, their records aren't very good for those patients. And so we can't match them because of record keeping issues. And so there are kind of, trade-offs in how to approach it. But I think what we have done is just to focus on folks who do look. Okay, so missing this in the people who were treated, who received a diagnosis before the election versus after, people who received the diagnosis before were slightly more likely to be missing in the prior election, but not statistically different from zero. It's like less than a percentage point. Same in the 2 years after the election. So again, now both of these groups have received diagnoses. Both are substantially more likely to be missing than they were in the pre-period, which I think is consistent with the expectation that some share of these folks have passed away. But it's not differential across these groups. I'm seeing some quizzical looks. I'm curious what do you?
I'm just curious what types of cancer they have then. It seems like most of these people are alive in 2 years, I think it's
Yeah.
good.
Yeah, at least, so that was my initial reaction. I made this plot and then I immediately sent it to the oncologist that's on our team and asked like, how does this compare to rates of mortality rates 2 years hence for these types of patients? He said this seems about right. So this is not my area, so I don't know. I'm completely relying on, it's a complete appeal to authority here. But that's what he tells me from his experience with these types of cases. Okay, so just in the last few minutes, I'm going to talk a little bit about mechanisms. So the kind of mechanisms that we've talked about, it seems like the room is especially interested in this, or persuaded by the kind of just decreased interest mechanism. What we've focused on thus far, because of our research areas, is really the kind of direct cost stuff, how it relates to how we run our elections. And so what we've done is a few things. I'll show you the first thing we've done is just look at patients who in the past election voted by mail versus those who in the past election voted in person. Now these people are different for a bunch of reasons. And so it's not like a perfect design for estimating the effect of, it's not of election administration, but tells us a little bit of something about their familiarity with mail voting. I'm going to skip over this. Yeah. So what we see is that the effect is substantially larger for people who have in the past voted in person versus those who on the left here voted absentee in the last election. And one thing just about the kind of details of this case is that people who that in California, if a lot of people who vote absentee are permanent absentee voters, meaning they are sent a ballot automatically by mail, and so for them, a change in election administration from the typical way of running elections to the current way of running elections in California, where we send everybody a mail ballot, there was no change, and so this is kind of we thought this was interesting in that it suggests that maybe there's some room for election administration to shape these effects. And yet, when we look at what was a change in kind of regime in 2020, where those who had previously not already been receiving a mail ballot were sent a mail ballot by default, starting in the primary in 2020. So this gray, it basically the effect. This is estimating the effect of diagnosis on turnout. The effect is almost identical to the effects that we see in the primary in general in 2016, and so. It's a little bit tricky, like if many of these people are already receiving mail ballots for the reason that somebody mentioned before, that in this state that's already has very generous convenience voting options, the change in election administration regime may not bite all that much for many of these people, and so we might not expect it to have that effect here, but it does not seem to have that effect here of dramatically reducing the disparity in participation across the healthy and sick. Okay. All right. So the kind of the punchline is that cancer diagnoses seem to reduce turnout by 3 percentage points. That access to and familiarity with convenience voting maybe is mitigating these effects, but that we don't see a clear reduction in the effects following the introduction of universal vote by mail. So the things that we're doing, I've talked about a bunch of these things already. I'm curious to hear what y'all are thinking about. But some of the things that we're planning to do, further rule out this differential mortality by linking to death records. A private vendor has death records that we now have access to. validate some of these matching things that we've talked about in here and health measures that we've talked about. Extend to other conditions. We have congestive heart failure, major depression, and some mobility limiting injuries are things that are on our mind, but I would be very curious to hear what you all think about what we should do, and then extend to the full UC system. So these are kind of the natural things for this project to do pretty much immediately. The next step, the next big thing is like how much we should invest in trying to build out this data in other systems to exploit cross-state and county variation over time and availability of convenience voting. I'd be curious to hear y'all's thoughts on that or other directions for the project. So thank you all so much for engaging so much with the project. I really appreciate this. Has been incredibly helpful feedback. I'm curious to hear what y'all think we should do next.